I've titled this, MASLD MASH is primary care ready to engage and automate. And I'm going to explain what I mean in a moment about automated detection of liver disease. Ultimately, we'll need imaging, but I think we can get quite far with tools we have in the laboratory. I'm going to focus a bit at Mike's request on people first language. Jörn already mentioned the change from non-alcoholic fatty liver disease to people living with metabolic dysfunction associated steatotic liver disease. If you think that's a long name, you never have to say it again. You can just say MASLD. We do that all the time with abbreviations like COVID, HIV, AIDS, and even JPEG, BMW, and M&Ms. How MASLD is the liver's expression of metabolic syndrome, what this means for metabolic health and the primary care pathway, and what works best for people in terms of MASLD models of care, to name the disease, to automate the diagnosis, and then to act on it. And as Jörn said, there are treatments on the way, but there's also a lot that can be done in terms of changing lifestyles, particularly improving diet and increasing physical activity. Jörn showed a version of this. I'll be focusing on the far left here in the MASLD and MASH space, but it is important to remember that alcohol has sort of come in from the cold, and we now have a MetALD that bridges alcohol-related liver disease and the metabolic dysfunction-associated steatotic liver disease when you're drinking some alcohol, but not enough to be labeled or diagnosed with ALD. So where are we now? When we conducted a survey in the four largest US cities, New York, Houston, Chicago, and LA, we found, on the right that while most people, but not everyone had heard of fatty liver disease, and not even every primary care provider, and this was a representative sample of primary care providers of people living with disease and that the general population had heard of fatty liver disease, many, many fewer had heard of MASLD. This was only 1 year after the new name, but it means it's going to be difficult to get people to come forward to get diagnosed, to ask about this, to really engage on this condition if they've never even heard of it. So this survey also showed very low awareness about the risk factors that contribute to MASLD. We need more studies like this one from the MASH Cities Coalition and with other partners to understand how aware people are of this disease and about what can be done about it. We're at a very, very low level currently. It was already mentioned that obesity and metabolic syndrome, diabetes type 2, for example, are major drivers of the MASLD increase. And here you can see the really high prevalence of obesity around the world, with the majority of those people living with MASLD. It was just last year that in a seminar paper in The Lancet that MASLD was mentioned. This is an image about obesity you see in the center, and really MASLD has many of the same issues around stigma and discrimination, many of the same comorbidities, as well as metabolic and mechanical and behavioral mental health complications. But now MASLD is being mentioned in obesity. It's not always mentioned in those clinical practice guidelines or action plans as it should be. And with type 2 diabetes, another indicator condition, driver, contributor, risk factor for MASLD MASH, where there's a very high prevalence. You see here, 65% of people living with type 2 diabetes are estimated to have MASLD, a third MASH, and 15 advanced liver fibrosis. Does it mean we should test everyone? It may not mean every single person, and clinicians will take that decision, but surely most people with this indicator condition should be tested, because the majority will have MASLD and a very large number, a third, will have MASH. It was just a few years ago that the field came together to develop a public health consensus around MASLD. There's a number of issues that are important for primary care. The awareness in general, but also treatment and care, what can be done in the primary care space, listening to your clients, to your patients, and getting the community perspectives, and then where primary care really fits in the model of care. When should patients stay, people living with the condition stay living with you? When should they be referred? Who should be tested? And how does all this interaction work so we have more efficient and effective models of care, with primary care playing a key role in that kind of MOC. I mentioned people first language, putting individuals at the forefront, um, of liver care. Language matters. And you see here on the left, it's about saying people, the person, and not just calling them by their condition. We want to avoid labeling and use neutral language. I won't read through all of this, but you can see a source at the bottom, the Fatty Liver Alliance, many leading associations of patient advocates, clinicians, and others have endorsed this language for better care, as well as an agenda for further research from the perspective of language and awareness. Jörn spoke about diagnosis, and Louise is a real expert, so she'll be speaking more about this. So I'll just suffice it to say that on the left, we need a workup after seeing abnormal liver function tests where there's elevated LFTs, they're abnormal. We're going to need more tests, and those can be done and even automated in the lab. It was already mentioned about incidental finding of fatty liver on imaging, and then targeted assessment as per the guidelines in people with metabolic risk factors, what we call indicator conditions, like obesity or type 2 diabetes, or certain combinations of multiple comorbidities that the clinician can determine warrant a test. And again, Louise will come back to that, and she will also go through some of the simple fibrosis scores. Jörn already mentioned FIB4, specific fibrosis markers, and the different kinds of imaging tests. And you see here FibroScan, which Louise has been leading a large clinic of. I think the future is already here. It's just not evenly distributed. Dr. John Dillon lent me this slide when we talked about how do we get more people diagnosed. So it's not just some due to incidental findings in tests, or a doctor deciding that for this person living with type 2 diabetes will test, but not another person, or at the next clinic they don't follow the same kinds of guidelines that were approved in their country or their international organization. So what Dr. Dillon and colleagues in Scotland developed was the intelligent liver function testing, iLift, which is a pathway that is a novel automated system designed to improve early diagnosis of liver disease, specifically in primary care. And here you see on the cover of JHEP, iLift, is it ready to be deployed in primary care? I think it is ready. This cover is from 6 years ago, so it still hasn't happened. But I'll show you some of the results, and you'll see how remarkable it's been, where it has been implemented, and now around 30,000 people in Scotland. Initial abnormal liver function test results trigger a cascade of reflex testing in the lab to help identify the cause of any liver dysfunction. And algorithms combine these results with demographic and clinical data, such as patient age, BMI, and alcohol intake, and fibrosis estimates to produce an electronic diagnosis and management plan for 33 diagnoses, including that fibrosis state. So, this is automation really meeting with clinical and clinical decision support. It reduces cycle times, bringing often as many as 6 visits down to just 1 or 2 when you're doing your regular labs. The same, extra blood can be taken, and the same visit can lead to the reflex testing. So you really only need 1 test, even if there are abnormal LFTs, one visit, and then multiple tests, and then ultimately a second visit if any results are positive and the clinician nurse needs to engage with the person living with that condition. Quality income outcomes have dramatically improved with iLift in Scotland, over 40% increase in liver diagnoses. And there's been a positively differentiated financial impact, a reduction in specialist referrals because people don't need to be referred because they've had enough lab tests that say they can stay for example, if they have MASLD without fibrosis in primary care, and then only moving the most serious high-risk cases to specialists. So cycle time reduced, quality outcomes improved, and cost savings. So all of this really, for me, leads to a paradigm shift where we're to people-centered care, where we're thinking about metabolic dysfunction. We're not focused just on a particular disease, but we're also looking at comorbidities, and we're looking at how to improve health-related quality of life. The impact on clinical practice, well, the new conceptual framework of metabolic dysfunction that I mentioned is central. Alcohol coming in from the cold, the new category of MASLD, a reduction in stigma and discrimination due to the new nomenclature. And we need to amp up, increase awareness, education, and policy, and draw on some recent key tools that have been developed from non-liver specialists. There's a lot of tools out there. Marco spoke from the ELPA perspective, Mike's at Fatty Liver Alliance, LPI, other groups can be great resources for tools for primary care physicians. You see here a new publication on nutrition in MASLD, a patient-focused evidence-based clinician's guide. At the Global Think Tank on Steatotic Liver Disease, we have a series of explainers you can look at. And we need things to be very simple. So from this new publication in Frontline Gastro, you can see, this is what the Mediterranean diet pyramid looks like. So when we're telling, and Shiraz Elbersagi and others will speak more to this, but when we're telling people that they need to improve their diet or have a Mediterranean style diet, we also can use pictures and images about what this really means. And when we tell them certain foods are harmful, we can also show them images of what those harmful foods are. And then, as mentioned, a great resource for primary healthcare physicians and others is to look at the explainers where we have simple cases and patient stories on the website of the Global Think Tank. So let me thank my team at IS Global and CUNY for contributing to this.